So, so like all the histories, we're going to start with the introduction. Wash hands while not washing, and just gel your hands, introduce yourself, and identify the patient. After take consent, I'm going to ask you a few questions. Is that all right? Then we're going to start with the presenting complaint. This is not a typical presenting complaint that we explore. This case fit. So we're going to ask about before, during, and after questions. So before, what was he or she doing? Where was he doing? Any warning signs? Any trauma to the head? So if we just seen the Canadian CT head rule, if the patient's had injury, had trauma, and had a fit, then there's an urgent indication for CT head and something's happening. So during is any witness. Probably one of the most important questions is got any witness. Usually it's a wife sitting together with me. And then she said, I passed out, couldn't remember anything, but she said it lasted for 2 to 3 minutes. And my right leg, for example, in this case, I said our right leg is moving rigorously compared to the rest of the body. So that is a focal deficit. How long is, again, important. Seizures lasting 20 minutes or more are prone to having very high risk of permanent neurological deficit. A few minutes, well, you may get away with it. Loss of consciousness, tongue biting, urinary incontinence, any movements of the whole body or particular part. Afterwards, any anesthesia, muscle weakness, muscle pain, loss of sensation, confusion, sleepiness. Did you injure yourself during the fit? And if you notice, my history-taking approach is slightly different in a way that relevant systems is up here, because I don't usually ask about the rest of the remaining systems. I only ask about a system that is relevant to the presenting complaint. In this case, this would be neurology. So headache, have you been having a headache recently? Do you feel sick? Were you sick? Have you got any weakness in your muscles, any weakness in your limbs, and any funny sensation, change in the sensation and such? So usually the patient may tell you, I've been having headaches for the past 3 months and the right leg weakness for the past 3 months. So the patient's had to fit or a seizure affecting the right leg mainly, and also had the right leg weakness for the past 3 months. And that is not coincidence, right? And then by the end of it, we've got a few differentials. What's happening? Malignancy. You can ask about the high temperature episodes, loss of weight, loss of appetite, and lumps and bumps in your body. That's lymphadenopathy. Space occupying lesions, morning headaches, blurred vision, and double vision. And then infection, rash, neck stiffness, photophobia, etc. And the cardiovascular is a chest pain, heart rate. You can connect with the past medical history. So the remaining is a pretty standard: past medical history, past surgical history, family history, social, including smoking, alcohol, and the occupation living status. When you ask about the smoking, important thing is always ask, have you ever smoked? Don't just stop, I don't smoke, and then just move on. And then the drug history includes allergies and the drugs. And the eyes is either consent and expectations. You can ask, if you've got any questions, do you have any questions for me? So that is pretty much it. I think that was a problem with the notes. So I'm just going to use the examination follow-up for the follow-up questions. Brain tumors, I'm going to use this one. So one of the differentials is the malignancy, obviously either primary or secondary, because this could be a secondary metastasis as well. What is the, if it's an elderly patient and if it's a brain tumor, what's the most common brain tumor in the elderly?
Glioma.
Not really.
Glioblastoma multiforme.
Glioblastoma multiforme
Metastasis.
is not very correct. Metastases. Secondary tumors are usually 10 times more common than the primary tumors in the elderly. What is the most common primary brain tumor? Brain cancer.
GBM.
Glioblastoma multiforme. That's the astrocytoma. Grade 4 astrocytoma, very aggressive, and prognosis is usually 1 year. Other differentials would include the TIA or stroke, as well as the infection, brain abscess, or the meningitis, as we said. What investigations are we going to do?
Biopsy, but first start with the bloods.
Tell me the bloods.
So the bloods, maybe some specific tumor markers, maybe full blood count, the coagulation profile, urea and electrolytes.
Anything else?
Just a routine blood, maybe glucose. And
So after the bloods, what's next?
imaging, CT, MRI with gadolinium.
Yes, analysis.
Well, we don't do CT with the gadolinium.
MRI, I said MRI with the gadolinium.
All right, okay. CT or MRI?
Okay. Yes.
I'm
CT
asking you,
maybe
CT
with
or
contrast.
MRI?
CT.
Why CT? You said it's a brain tumor. Why not MRI?
Yes.
If the patient have
The
traumatic,
answer is it depends. All right. If it's an acute setting, we do CT first, followed by MRI in these subacute settings, usually after a few days. Why? You need to rule out hemorrhagic stroke. So may need to rule out stroke. And if it's a tumor that you find on the CT is not very good at looking at the soft tissue, not have a good soft tissue contrast. So you would need to do the MRI later on. But if I'm seeing this patient, not in the emergency department, but in the outpatient setting, elective setting, I don't need to do the CT, just the MRI. Well, so routine blood test, full blood count using ECRP, LFT, clotting profile could have been saved, and then confused. If the patient is confused, especially, then we'll do the confusion screening for the metabolic arrangements as well as the infections. Fundoscopy, you can see the papilla edema, ECG, chest X-ray, EEGs, and CT or the MRI, and later on biopsy if required. What's the management?
it depends upon the patient condition. If it's stable, we will go for investigation, then examination, then manage accordingly. If it turn out to be tumor, then we will discuss an MDT and stage it and discuss an MDT. And after the MDT discussion, we will plan a treatment. It can be surgery, chemotherapy, radiotherapy. We will discuss this with the patient and consult the patient, and then accordingly we do that and do follow.
Very good. Well, these patients are usually, the patient's stable, talking to you and well, right? So we're going to take the other approaches to that. So we're going to start with the MDT, neuro-oncology MDT, where the neurosurgeons, neurologists, oncologists, neuroradiologists, specialist nurses will attend. And we can give benzodiazepines for the seizures, right? And corticosteroids, especially steroids for reducing the mass effect if required. And then stereotactic radiosurgery or the gamma knife. It's the first line nowadays. Radiotherapy, that's a traditional external beam radiotherapy, chemotherapy, or if there is a very, very big tumor or the superficial tumors, then we'll consider for the open surgical resection as well.